Doctor on Air is brought to you with the compliments of Lusaka Apex Medical University. Lusaka Apex Medical University. Knowledge and excellence.
Afternoon. Thank you for joining us. And this is Doc on Air, where we bring you your doctor with different ailments, in terms of the doctor talking about different ailments right into your living rooms or wherever you are watching us from. And today, the doctors that we have are Professor Tackson Lambart. He is one of the 8 founder members of the Lusaka Apex Medical University. And we have Dr. Isaiah Yikona, Dean, Facility Medical Radiation Sciences, consultant in radiology as well. Thank you so much for coming through, gentlemen, to Doc on Air today.
Thank you very much.
So today our concentration is going to be on head injuries, head trauma. What causes those? We're going to get into those. How do you make sure that if this has occurred to you or somebody who is in your household, how do you go about them? We are going to be making sure that we discuss how they occur, the severity, and also treatment and aftercare as well of this. So this is what we're going to be discussing today. If you want to be part of our conversation and of course just getting to ask questions in regards to this, get to our get to your phone and get to your screens to see the number that will be scrolling on your screens to make sure that you are in touch with us. But let's start with this one. The classifications of these head injuries, which are they?
Thank you very much. Thank you. There are 4 classifications we talk about, and each one of them I'll give an example so that people can understand what it means. The first one, we call it general classification. There are 2 words we use there: open head injury or closed head injury. So for open head injury, any wound that goes through the 5 layers of the scalp and the 3 layers of the scar, and the wound has gone deep behind the scar within intracranial space, then that is an open head injury. A good example is when a patient is coming to the ward and he has been involved in an accident and there's the CSF leaking in the ear. That is open head injury. And then the closed one. This one, a patient comes, no scratch, no bruise, no laceration on the head. Smart. And yet there's severe injury intracranially. So what happens in this case is that someone driving at a high speed, and he has a seat belt on, and then he meets another vehicle coming, and then they are head-on collision. The patient won't move off the seat because there's a seat belt, but the head will flex and extend. That violent movement of the brain in the head will cause brain contusion, which means the injury to the brain, and then the veins that drain the brain to the superior sagittal sinus. There are 12 on each side, and those veins can be torn, either one side or both sides. So what is developing there is the subdural hematoma. Subdural hematoma is very traumatic, and in combination with brain contusion, these patients reach the admission ward unconscious, deeply unconscious. So the doctors will tell this level of consciousness. We'll come to that. This is the general classification. The second classification is the mode of injury. And this one is what kind of injury has occurred that has affected the head. Mode of injury. So we look at velocity. Like high-speed vehicles. What they call neck braking speed, 140 kilometers per hour. And then in an accident, that kind of injury will be very severe. So mode of injury, we look at it in the history taking. The other one is the pathological classification. At the time of impact, the doctors can't do much about the impact trauma to the brain because that has occurred at the accident site. That we call primary injury to the brain. The secondary injury to the brain follows even after admission. If we are not giving enough oxygen, for example, if the blood pressure is dropping instead of rising, that brain will be damaged very badly, especially where there's polytrauma, multiple injuries, in the chest, abdomen, the legs, multiple injuries. That patient is in more severe condition, and we can lose the patient if you are not careful. So that is another example. The last but very important, the fourth one, is what we call clinical classification. So our students, our doctors know how useful it is to know clinical classification. So almost all health workers should know. We use this for Glasgow Coma scale. So this scale is the 15 out of 15, the highest. If a patient has been brought in the ward, 15 out of 15, 2 hours later, he loses the marks, is 12 out of 15, we start getting worried. So how do we score 15 out of 15? Eye opening. If the patient is opening spontaneously the eyes, we give you 4 marks. If the patient says who he is, where he is, what time it is, we give, that is the verbal, we give you 5 marks. Then when a patient says, oh, can you lift your arm, open your eyes? No. Bring out your tongue. If it's obeying instructions, we give you 6. So 4, 5, 6 is 15 out of 15.
Okay.
Now 2 hours later, a patient is not opening eyes spontaneously. You have to ask, please, Mr. Pede, look at me. That's when you open eyes, we give you, instead of 4, we give you 3. If the patient is disoriented and confused, we don't give you 5, we give you 4 out of 5 for verbal.
So when you
so now the motor one, we reduce it from 6 to 5 if it's not obeying instruction, and we press on the sternum, and the patient brings his arm to remove you because you are pressing the sternum. Then we say it is localizing pain. So they lose 1 mark, 1 mark, 1 mark. 3 from 15, they are at 12, 15. The lowest is 1, 1, 1. Because even those who are not responsive, under eye, verbal, and motor, we don't give you 0. We give you 1, 1, 1. So the lowest is 3 out of 15.
Okay. When you classify them like that, and when you look at everyday happenings, what's the most common type of head injury that is received in hospitals or that occur that you've heard of from your experience?
Yeah, I think from me, I think my senior man here will say something because he's on the diagnostic part. But what I say is what has gone up so much now is the road traffic accidents.
Okay.
That's number 1. Maybe assault cases are coming and also falling from height at the construction sites. If they don't take care of tying the rope so that if he falls, he's held by the rope, he can land down with the head first.
Okay. All right. And for you, Dr. Yikona?
Yes, it's very, very important to know how to combine the receiving doctor's evaluation and how to evaluate the patient. We've heard the types of classifications, but on the radiological side, these days we call it imaging. You have to image the head and see what is going on. Previously, we have been using X-ray of the skull films. But with time, we've been able to say X-rays of the skull have limited value because you are really looking at the bone. You are not sure, or you are ignorant about what is going on inside the skull bone, the brain itself. And the brain has several compartments. You have the covering, and the covering has its own membranes. You have the brain itself, and even with the brain, you've heard that you have lots of vessels, both the supplying vessels, which we call arteries, and the draining vessels, which we call veins. And these come in various categories and complexities. So, since we don't have the privilege in all our health facilities to do the more definitive and more sensitive imaging facilities, unfortunately, in most centers, particularly in our rural settings, we rely on X-ray of the skull. Now, the X-ray of the skull, the best evaluation is whether there is a fracture or not. And the fractures come in different ways. You can have a line, and you say that is a linear fracture. You can have a fracture which is overlapping the skull. We call that a depressed fracture. And that is very, very serious because almost invariably it will depress and cause impression on the brain substance.
Okay.
Then you have the membranes which have serrations. Those, with time, they come to close. We call them sutures. If you remember, even in tailoring, you can suture. But that's what happens. And those can also be subject to a fracture going through there.
Okay.
And then you can have a combination of those.
When I hear the kind of fractures you're describing,
Yes.
when Professor Lambart was talking about, the classification of these head injuries, and you've also mentioned issues of, how sometimes in the rural areas, issues of X-rays. What can a person who's been in an accident, let's say the people who found him, what can they do to help? Or maybe there's a person in the car who also has, he's not as injured as the other person who's received the head injury. Or now, another scenario is a person who's in the rural areas, they've had an accident and they're buying some time to get the person to the nearest hospital. What can they do in that space to also help you so that when they get to the hospital, they have a situation where you can also, it's easier for you to help and worsening the situation before they get to the hospital?
At local level, we've said limited because we can only use X-rays.
Okay.
But the important aspect is what Professor Lambart talked about, evaluation of the patient in terms of conscious level. How are they? Even the ones who are with them, because trauma comes in various forms, either one person or various persons, particularly with road traffic accidents. We've had this one severely injured, that one not so much. But with modernity, the best is to do what we call CT scan, computerized tomography. This will evaluate not only the scalp part, not only the bones, but it will evaluate also the membranes, the covering of the brain, and the brain itself, and the complications. Because the findings will influence or assist the doctor as to how to handle the situation.
What about positioning, Professor Lambert?
Yes.
Carrying the person, how do we lift the person? How
Yes,
do we move them from the accident scene into the car that's going to help them get to the hospital? Positioning.
Yeah. For example, road traffic accident, which I said, if people are on a flying speed, it's what they call it a neck breaking speed. They know it. Our people know that very high speed, 140, it will break the neck. So what I'm trying to say is that at the accident site, the people who are there should protect the neck more. Because if the neck has been fractured and you handle wrongly, you will paralyze the patient completely, all the four limbs. So what we advise, improvise and put a collar, neck collar like, to support the neck so that you don't complicate things. The rest you handle carefully. If you are on a stretcher, you can really put on the stretcher, protect the neck, but the most important, those people should not waste the time. Any head injury, you must rush to the nearest health center.
Okay.
So that the trained people, because the nurses, the doctors, the clinical officers, physiotherapists, they know how to handle the patient. But as we go along, there's also paramedics who can be involved. And I think our police officers may be trained how to do first aid. So it's a collective responsibility. But immediately the patient is taken to the hospital, the doctor or the receiving doctor will quickly assess the patient to prevent the secondary brain damage. For example, we call it ABC, airway, breathing, circulation, deformities, those will be taken care of. At the same time, they are doing vital signs, blood pressure, pulse rate, respiratory rate. They are entering as the baseline. So the evaluation starts from there. If there's need of a drip, send blood for grouping and cross-matching. And by the time the consultant is coming, the receiving team will have already done most of these things.
Okay, all right. You are watching Doc on Air. Before we go for a commercial break, remember this program has been brought to you courtesy of the Lusaka Apex Medical University, and our concentration for today is head injuries. I have two gentlemen in studio with me who are helping us dissect this, talk about it. I have Dr. Isaiah Yikona, Dean Medical Radiation Sciences, and also a consultant radiologist, and he is coming from the Lusaka Apex Medical University. I also have Professor Tackson Lambert. He is one of the 8 founder members of the Lusaka Apex Medical University. When we come back, we'll get into issues of possible complications, but for now, here's a break.
Your aspirations of healing mankind and a high-profile career are made possible here at the Lusaka Apex Medical University. We offer high-quality medical education with the best technology for your learning. You will learn from professorial teams dedicated to academic quality and standards. Enroll with us for Diploma in Physiotherapy, Nursing, Midwifery, Bachelor of Medicine and Surgery, Pharmacy, Science in Nutrition and Dietetics, Physiotherapy, Environmental Health, Public Health, Diagnostic Radiography, Nursing, Masters in Public Health and Radiology. In the new normal under COVID-19, we offer online classes where our students can interact with their professors. LAMU, where knowledge and excellence meet.
Doc on Air. The number that you should call us on is now scrolling on your screens. Get to that. And remember, we are talking head injuries. Ask your questions, give us your comments, or maybe share a story regards to head injuries that have occurred, or any questions that you want to ask our two doctors on air for you today. Before we went on that break, you were telling us the positioning of where, you know, the person helping can just help the situation than worsen it, especially when the injury has just occurred. But what are the possible complications if a patient delays for medical attention? You stressed on it before we left. Maybe Dr. Yikona can get to the complications.
Yes, What we discussed initially was the immediate evaluation. But there are late complications which we can classify into two. 1, 2, 3 hours later on, maybe even 24 hours, that can be a late complication because whatever's going on, for example, if there's been a bleed and it's causing a mass effect, that will continue and become bigger and cause more complications in the patient. And those can be on top of the brain, the membranes, and even vascular tears. You heard about the need to particularly pay attention to the neck. So when you have injuries, particularly of the base of the skull, very, very, very often you have injuries to the upper part of the neck of the cervical spine. So those are late effects in the immediate time, 48 hours, 72 hours. Then you have late effects, which I can classify as later, where you sometimes even discharge the patient, but later on, a week or 2 weeks later, they start manifesting complications, maybe up to loss of memory or inability to move limbs and so on and so forth. Those are late complications. And so in radiology, we still support our colleagues. You can do, in the initial stage, the imaging, and then, depending on what is found, you can say, let us wait. Let's do it again in another 48 hours. Or, let's wait. We are not happy about this. Let's do it 2 weeks later, even a month later. Because these things can become worse. There is very often brain swelling, which you can call edema. But in the initial stage, you may miss what is causing it. And sometimes, if it's bad enough, part of the brain at the base can start going out. And usually, sometimes, even when you have a bad fracture, a bit of the membranes of the brain can protrude outside the skull. So these are complications which we need to be aware of and alert ourselves as a team, because those complications can occur well after the initial trauma.
Okay. Prof,
yes.
How common are head injuries in Zambia? And are all these injuries to the head, to the brain, caused by these physical descriptions you've given us, or sometimes internal metabolism somewhere, I don't know, causes some injury to the head?
Head injury.
So it's two questions there. How common and...
How common is getting very common. Very common because as the number of vehicles are increasing on the road, and then this highway driving, high-speed driving, they are really causing a lot of head injuries. Yes, and even on the bicycles, I hear Chipata hospitals, they are receiving a lot of injuries from bicycle accidents. So it means it shows what mode of transport, but high speed, they are notoriously bad. I wanted to add on the complications, how our doctors and nurses can quickly recognize at the time of admission. What happens that when there's the intracranial hemorrhage, hematoma, which Dr. Yikona referred to, and let's imagine it's on the left side of the brain, and it's collecting and forming a mass lesion, including the brain swelling, edema, and the hematoma, the brain will start moving away, shifting, and that is a very delicate situation occurring if you delay the diagnosis. When the brain is accumulating, because the sky is a closed box, so the brain will be pushed from high pressure area to low pressure area. Now, supratentorially, The cingulate gyrus, this is the most
Kindly
medial.
hold your thought, Prof. Let's
Yes.
accommodate our first caller. Welcome to Doc on Air. Talk to us.
Yes, good afternoon, madam.
Good afternoon, sir. Talk to us.
Yes, I think, can I use Bemba?
Yes.
London Mkwai.
Mkwaye, ndeko kuipusha kwa hii program ninji konka. Na alikuwa tawa madamu, na kwa tawa chaku tiyezi. Nomba, wale nusa sana memory, wale nusa sana memory. Ero na kairi nango na vekala, wale shikula. Nango wale eria, wale shikula na kinti filepo na uminwe. Ero kabiri na hapo wabike chinti vine mine tishina walaba. Kena ena uti haba nipo ulo miamsa mashari kwa uti. Na tiwa wanandowela kuna inaishi.
Did she have any accident hitting to the head?
Bali po mu accident ya umine kumutwe.
Awe tuwa mu accident bali kutoka fechimo kwa tiki tumopa mutoba kali mene placement kwa tumuko sfi. Bali batero operation batawa hapo mu accident hao.
Chame nene kuisa Mkwai. Chame nene pesa position kumutwe.
Yetumina kumpulungu.
Mkwai nombe chomlela ndachi chame nene. Ni kuisa hapa side chame nene kumutwe.
Chame nene pa mutwe pakati hapa. Mpepena pa mutwe pakati bati mumba pa sono kumutwe Mkwai. Vile tunasema pombo vile tumena filia. So bali batero operation bakunya mwati adichiri futa. Kama adichiri futa filia.
Ngamwa balolesha chale moneka?
Hello?
Ngamwa balolesha chale moneka na men Sofia yaye na Yesu nangu mpaka bapita mama machine ya hospital.
Na men sene wala kufuata tawaro wekisa na men sene.
All right. Okay.
So I think that one, it's not only head injury that can affect the brain, even other infections it can, but we want to say that the memory center is the temporal lobe. We call it the hippocampal gyrus.
Okay.
So, and it can be affected by a lot of illness. And if she's drowsy and all that, we didn't ask how old she is.
She said she's over 30. She's in her 30s.
30s, a young lady.
Young.
Okay, young. So what in this case is better to investigate. And one of them to be done is the EEG, so that we see the electrical activity of the brain. And then CT scan, which Dr. Yikona talked about, to see what is happening intracranially. And the personality change, maybe the frontal lobe is getting affected by the process of the disease.
He was saying she had a lump previously that you could even physically see. So there's the issue of the sleepiness from nowhere.
Yes.
And then the
And
forgetfulness,
that kind of a lump, we wanted to
drowsiness.
get a histopathological report. What was it? Was it primarily from the site we are looking at? Or was it a secondary deposit from somewhere?
Okay.
In
Add on,
addition,
Dr. Yikona.
In addition, you see, what we've been talking about is a normal skull. But even when we do imaging, CT or MRI, there are combinations. A normal response to a normal trauma, the normal bone texture, the normal brain. Then there is what we call unusual response to normal trauma. So you just hit somebody a little bit, then they are fractured. That's how we also pick up on radiology that although there is a head injury, this bone, this brain was already diseased. So that is just an aggravation. And then we have not talked about the other type. We don't see it so much, but these days it can happen. Normal response, but very unusual or abnormal trauma. Okay? The military know a lot about this when you have a blast injury. You see? And he has talked about very high speed trauma, not normal speed. Normal speed you might survive, but high speed you find that there are so many bone fragments. So those are findings which you can pick up on radiology. Diseases which will affect, because it sounds like the lady may have an underlying disease which needs evaluation, and that 30 years and so on is possible, is amenable to either surgery or drugs or combination.
So our caller is in Mpulungu. Where's the nearest place he can get such
Mpulungu,
Yes.
anyway, I was there
for all those-
79, but I know that Mbala General Hospital
Mbala?
is very advanced.
Okay.
Even Mpulungu itself has got a good medical referral system. They can be helped there. But if they can't do it there, we have available referral system. And they can refer to where the CT scan is available, like in Ndola.
Yes.
Okay. All right. Okay. So batata, I hope na mumfact mumbala nangu mumpulungu mumwinemudi, then you can get her checked because she needs to be assessed so that you can get the correct answers. You are watching Doc on Air. We are concentrating our efforts on head injuries today. We have Dr. Isaiah Yikona as well as Professor Lambart in studio to help us talk about this. You're watching Doc on Air. Let's go for a commercial just to say pay courtesy to the people who've made this program possible, and this is Lusaka Apex Medical University.
Your aspirations of healing mankind and a high-profile career are made possible here at the Lusaka Apex Medical University. We offer high-quality medical education with the best technology for your learning. You will learn from professorial teams dedicated to academic quality and standards. Enroll with us for Diploma in Physiotherapy, Nursing, Midwifery, Bachelor of Medicine and Surgery, Pharmacy, Science in Nutrition and Dietetics, Physiotherapy, Environmental Health, Public Health, Diagnostic Radiography, Nursing, Masters in Public Health, and Radiology. In the new normal under COVID-19, we offer online classes where our students can interact with their professors. LAMU, where knowledge and excellence meet.
Oh, that and more from the Lusaka Apex Medical University. Before we went to talk to our caller from Mpulungu, you were...
I was trying to explain if there's a blood clot intracranial and is pressing on the brain, which is already contused. So what happens there, supratentorial compartment, is that pressure buildup, it will force the brain to go to the opposite, away from where pressure is. So on top there, most medial part is what we call cingulate gyrus. That gyrus starts pushing under the falx cerebri and is pushing to move away from where there's high pressure. But when doing that under the falx, and I know that our doctors and our students are also listening, under the falx there, the pressure there, that's where anterior cerebral artery is passing through to supply the leg position
Again,
on the brain.
you have to hold your thought again to finish explaining that one. We have another caller on the line. Good afternoon, you're through to Doc on Air.
Good afternoon, thank you, madam.
All right, go ahead.
Yes, my name is Ahal and I'm calling from Zimbabwe.
All right.
Yes, and I just want to say that I'm listening right now and I'm watching and I'm following the program.
Appreciate.
Yes, and the topic happens to be head trauma and the injuries. I just have a question which goes like this. On alopecia. Alopecia, if I'm to define what alopecia is, that is failure of the words to be pronounced the way it's supposed to be pronounced. Now, my question is, could alopecia come as a result of head injury, or it has got to do with a problem with alopecia?
All right. Thank you very much.
Speech problem.
You, Dr. Yikona, you're...
No, he's talking about alopecia. Alopecia is really lack of hair. Or
Loss of hair.
Loss of hair. Baldness. So baldness comes in various forms. Some within the family, they get it very early. Some with age, you lose hair, isn't it? But hair has this own protective mechanism, but not as good as maybe the scalp itself or the bone. But I think what you are trying to allude to is if you have no hair on your head, are you more prone to injury or not. I think this is my interpretation of his question.
That's what I think he was leading to.
Yes.
Maybe I should come in. I think he also mentioned about speech. But in terms of protection, the brain is the most vital organ God gave us in time of creation. The most vital is the center of everything. And there are 11 layers to protect the brain. The scalp, 5 layers. The skull, 3 layers. The meninges, 3 layers. If you add up 11 protective layers. But also, if he was referring to speech, the frontal lobe, yes, the speech has a special center, which we call Broca's area. And if it's injured on the dominant brain, that's the point I wanted to. Dominant brain, for example, the left
that's why
the
you were even
cerebral
going with the
yes,
explanation earlier.
I was going to that. The dominant brain is the one that carries the speech center. So if it's traumatized, a number of things will happen. The speech will be disturbed. And also there's a language center. There's a speech center with fluency in it, but also a language center, Wernicke's area of the brain. But that one is towards the end of parietal temporal brain, posteriorly. But the speech is in the frontal lobe area. So it can't be disturbed. And to say whether it's the speech due to injury of the speech center, you can ask the patient, can you protrude the tongue straight out? If it is able to do that, you know, there's some chance of recovery. But the other point I was trying to say is the cingulate gyrus will paralyze the leg, but the most damaging is the one which goes to compress at the midbrain, because the midbrain compression will lower the Glasgow Coma scale. The patient will be becoming more deeply unconscious. And our people should know quickly, if a patient level of consciousness is dropping down, something is happening in the head. Then we also look at the pupil size. If one side the pupil is getting larger, the eye is telling you there's a blood clot on my side. Please do something. The pupil is dilating. Yes, the mass is getting larger, the hematoma is getting larger. So that enlargement, and our health workers know what it means. Then when you check power on the opposite side, contralateral, the patient is getting weaker and weaker on the other side. Or what it means, there's a blood clot which is causing pressure and is causing brain shift over the midbrain. So that is very dangerous, and we should take care of that patient quickly. We don't want that patient to die, so we must move in, do quick investigations, and evacuate the blood clot. Now, to remove those blood clots, you have to open the scar. You can't make one hole and you are removing blood clot there. No, no, no. You must open proper opening of the head, scar flap. Then you remove all the blood clots. Patient will survive.
Okay. Let's get another caller. Good afternoon. You're through to Doc on air.
Afternoon, good Judith, and good afternoon, the panelists.
Good afternoon.
Go ahead.
Yeah, thank you. I'm enjoying the program.
Appreciate.
Thank you. I just wanted to add something. I've had this challenge of, I'm in the same field, I'm a radiographer at the district.
Very good.
Yes. So, but the question that I have is, I don't know if what is the ministry doing to ensure that we have such services in some of the in these facilities that we work from, because these are some of the issues that we usually tackle in most of these centers that we work from.
Okay, thank you very much.
Yes. Then the other thing is how safe is the usage of radiation when it comes to head injuries, because in most cases, the best alternative that we usually have with the radiations, in most centers we don't have, in most facilities we don't have MRI and the CT scan services.
Okay. All right, thank you. All right. So the first one, I know you cannot speak for the ministry, but through your interactions, I don't know how some of these issues are being tackled, especially for the one he's talked about, the first one, where he's asking what the government is doing in terms of what, not speaking for them, but for the interactions, what has come out, or if there's been any.
Yes, maybe you want to, that's your young man.
No, quite right. The ministry is aware of our limitations in the periphery as we go from the central hospitals. But I know that they're addressing this issue. It keeps coming out, and it's cheaper to get the facilities as near to the population as possible. I think this has been the message throughout. But the facilities which we need for radiology are not so cheap. But I know that they're decentralizing the radiological services so that we have CT scanners. I know most provincial centers now are having that. So there's no question of it being ignored.
Okay.
In the meantime, I'm sure the ministry is also aware of the need for a service to quickly evacuate a patient from one center to the next level, even beyond, for appropriate attention. This includes even our flying doctor service. So those, I'm sure, that are on site, and every center has an ambulance.
Okay. He was also asking the issue of how safe it is to use.
Yes.
Yes.
Then he's talking about radiation safety. Radiation is all over, even as we move around, there's radiation. But in our practice, you decide as a team the radiation exposure compared to the benefit, which is better. There is a radiation exposure, but it's minimal compared to what you get out of doing the radiation procedure. But even then, every radiation worker is trained how to minimize radiation exposure by both protecting the operator and protecting the patient. Also, protection of, for example, if Professor Lambart comes accompanying the patient, we have to protect him, the nurses, and so on. So there is already a training of radiology workers on how to minimize radiation exposure.
All right. Let's get another caller. We have somebody on the line. You're through to Doc Onea. Talk to us.
Yes, my name is Elas Pinkala from Lusaka Chawama. I just wanted to ask a question about, for instance, a premature baby and internal injuries. What can happen? Or I mean, what are chances of surviving? Are very high or low? Because there, some mental organs such as brain are not yet completed formed. What can happen?
All right. Yeah. Thank you very much. So he's taken his a premature baby with such.
Yes.
Does it affect other organs?
No, I think it's a very important point because the brain trauma can occur at the time of delivery, and especially where you are forcing a lady who has not been properly assessed, because some ladies don't go for antenatal, and we should encourage antenatal care. Why we do that is that we want to assess the size of the baby and the passage to deliver the baby. So if the premature baby, especially the brain is very, fragile, when you are delivering such a baby, trauma, what happens is that the bones, they squeeze the brain. By the time the child is being delivered, has a severe brain trauma. And those are the children who may, if we don't rush, because such a child will not cry quickly after delivery. It's a flat child and premature. That's why we take to departments like D block, neonatal ward, to support oxygen, incubator, until the child is growing. But if there's a trauma, and there's the bleeding in the head or hydrocephalus is forming, those are the children who grow with a head which is growing bigger and bigger. And then the diagnosis will be made, then the shunt operation will be done.
Wow. So I hope you've gotten your explanation there. Now let's get to how these kinds of injuries can be detected.
Well, I think
I know you've touched on it a bit.
the
but in
diagnostic
detail,
part, yes. But I wanted to say that even the one who called from Mpulungu, the most important in a rural setting is a good history, good physical examination, and then suggest investigations. So 60% of our diagnosis, if you are doing a good history, you will have secured it. The remaining 40% is physical examination and then investigations. So teamwork is very important. Who is your clinical officer on site or the doctor, the nurses? They work together. Head injuries, they can easily pick that this head injury is getting complicated. And as the Dr. Yikona said, you call for help. You know, if there's a flying doctor service, they'll come.
You quickly call them,
Yeah, you
isn't
can
it?
easily
Let's hear what
the
our next
patient.
caller has to say. You're through to Doc on the air.
Hello?
Talk to us.
Yes, please. Yes, we're waiting.
Sorry.
All right, you're here. Talk
yes,
to us.
Yes, waiting. Yes, evening.
How are you? Please talk to
Yes,
us. Go ahead with your comment
yeah,
question. We can
Yeah,
hear
yeah,
you.
yeah, yeah. I'm calling you from Mazabuka.
All right.
Good.
Yes, Lambart, Tumaten.
Ibwino bwanji
Nina vile msinyanja.
zikom.
Inga mafit na trauma vukata na tiani. What's the relationship? Trauma and fit. How do they relate to each other?
Yes, very true.
All right. Thank you very much.
No,
Okay,
a very
welcome.
important
Very
question, you
Yeah.
know,
Okay, okay.
because it traumatized the brain, the frontal lobe, anterior part of motor cortex. If injured and the patient is hearing, one of the complications is the focal fits, like a Jacksonian in some cases. But the focal fits is that the face and the lips, they are fitting, you can see. But if it's breaking through, it will go and affect through corpus callosum. Both brains are in fitting mode. That go into grand mal fit, serious fit the whole body. They can't breathe for a while, tonic, and then start moving the muscles, chronic fit. And they can even bite him, a patient can bite himself and all that. So I think it is related to trauma. It's one of the complications of head injury, and it should be avoided. But when a patient is fitting like that, we must investigate. Can we confirm? There's the ECG, electroencephalogram, should be done, it's very specific. And also see whether there's any trauma that can be picked by CT scanning, which Dr. Yikona referred to. These days you can even refer for MRI.
All right.
Not only that, healing process comes in various forms. One of the common forms is scar tissue.
Scar tissue.
So scar tissue in a critical area can be a focus which precipitates fits. Sometimes you have not only scar tissue, but deposition of what we call calcium in the calcific that can also cause fits. But as my colleague has said, it's important to know what sort of fits.
Yeah.
Is it generalized fits, or they start from somewhere then spread? That will give an idea of what sort of fits one is dealing with.
Okay. And that, as we come to, towards the closing, in terms of your remarks, for those who caught this conversation halfway through, when it comes to head injuries, your takeaway points from Dr. Lambert to Dr. Yikona.
Yeah, for me, I think my points are that, please, let's reduce the speed. Our Vice Chancellor, Professor Munkonge, his highest speed is 60 kilometers per hour. We should learn. Because I overtook him one time, and he called me to the office, come. I saw you driving very fast. What speed were you driving? I said, sir, I was going at 80 kilometers per hour. No. That is too high. You should be going, not to go beyond the 60 kilometers per hour. How can you cover a long distance? I said, no, you should be starting off in good time.
So that you don't.
So you don't speed.
And for you, Dr. Yikona.
No, for me, head injury or head trauma is very important because the brain is the seat of all the functions. So please, whether you are directly involved or a neighbor or a friend, seek medical attention immediately. If everything is normal, doesn't mean there are no late effects. You need to be followed up and be checked to make sure you are as perfect as can be.
All right. I appreciate you gentlemen coming through. And of course, a very big thank you to Lusaka Apex Medical University for making these conversations possible. Today on Doc on Air, we've been concentrating on head injuries and we've dissected them. And of course, this conversation can go on. But for now, in studio, we switch off the lights and say thank you so much to our viewers and the callers who also came through to ask their questions and comments. On behalf of the entire production crew for Doc on Air this afternoon, my name is Judy Ngulube. Thank you very much.
Here at Lusaka Apex Medical University, you can pursue your dream career today by enrolling with us. Apex stands out as a modern, privately owned medical university that aims to produce highly qualified healthcare professionals while molding them into exceptional members of our Zambian and global society.
The Lusaka Apex Medical University has been producing highly qualified medical personnel over the last 6 years. This is an effort to complement government effort in training highly qualified medical staff to fill our institutions and fill the needs of the country as well as the region. We are therefore inviting you to join the medical community through being part of this university as you train in the health profession, where we, founder members, participate in the training of our students very actively.
We have highly qualified, self-motivated and experienced lecturers, affordable tuition fees, and state-of-the-art equipment for learner-centered lectures and small group teaching for quality education. For more information about enrollment and fees, contact admissions on 0974 137 203. Lusaka Apex Medical University. Knowledge and excellence. Doctor on Air was brought to you with the compliments of Lusaka Apex Medical University. Lusaka Apex Medical University. Knowledge and excellence.